No, thank you for telling me that. So I'm Dr. Brook Niemiec. I'm a board certified veterinary dentist. Co-speaking with me is Dr. Stephanie Hahn, a board certified anesthesiologist. And we work together quite often, taking care of pets that either are older or have comorbidities. And like we said in the little teaser for this presentation, if you've ever been told your pet's too old or too sick to have anesthesia, it's probably not true. There are exceptions to that rule, but they're pretty far and few between, which I'm sure Stephanie will cover here in a little bit. So my job is to tell you why you need to do dentistry on your pets and why you should be taking care of them. And Stephanie's going to be telling you why we can still do that. And then again, like I said, we'll take any of the questions that you guys, whether it's veterinarian or a client, we're happy to take any of your questions. So what are common senior dental issues? And this is a dog presentation. Stephanie and I just talked about we should do a kitty one in the future, so we probably will. Be on the lookout for that. But periodontal disease, I mean, that's the number one problem in pets of any age, really. Dental, and it's really the most important or most common thing in pets, period, as they age. So tooth fractures from tooth resorption, we'll see. I'll talk about that. Cancer, obviously, extractions are a challenge, and intrinsic staining we'll see as well. So I'm just going to run through. I'm going to, this is more of a client-facing thing. So one of the things we see incredibly common is what's called an uncomplicated crown fracture. And that also is called a chip fracture or a minor fracture. And what this means is that the crown is broken, but the root canal is not directly exposed. And just so you all know, in dogs and cats, the enamel is less than a millimeter thick. So any loss of tooth structure is going to expose this underlying tooth structure called dentin. And dentin is a living structure. And it has all these millions of tubules that run out from the root canal out to the periphery where they're covered over by enamel. When you expose this dentin, it creates sensitivity. It's just like if you guys have ever had a sensitive tooth. And these tubules do communicate with the root canal system. So we call this indirect pulp exposure. And then the roughness of these fractures lead to increased periodontal inflammation. So the things that we're going to see in our larger breed dogs, typically, in general, small breed dogs get gum disease. Large breed dogs break their teeth because they're orally active. They chew on things. So when we look at this, what you can see, this is that shiny, bright white enamel. This kind of dark stained area here is the dentin. And the reason that it's stained is because it's porous and it has those millions of dentinal tubules. And each one of those dentinal tubules contains essentially a nerve. And that means that these animals are painful, just like having a sensitive tooth, and they can get infected. A study that we published a few years ago showed that about a quarter of these are actually infected. So if your pet has one of these, they should be treated. They absolutely need to be. And yes, I know. And the whole theme is they never show their signs of pain. But this does hurt. And then if it's not treated, it can get infected. So how do we treat these? Well, depends on dental x-rays. If there's no pulp exposure and we take an x-ray and it's normal, I'll show you an abnormal one in a minute. But if it's abnormal, we recommend a procedure called a bonded sealant, which is basically a very minor filling, like going and having a filling done, but it's even more minor than that because it's clear. It just goes over the tooth. And it works really well. And then we always have to talk about, yeah, as dogs age, kind of like you and I, the reason these things break as they get older is that instead of bending, they break. And it's because the bone gets harder and the periodontal ligament gets smaller, so they tend to break rather than bending. So things that a dog could chew on when they're 2 or 3, they can't chew on when they're 8 to 10 because it will chip these teeth off. So when it is, we need to treat it, like I said. So doing a bonded sealant if it's not infected, but like I said, about 23% of them will have this x-ray. And this is that tooth I just showed you. And this tooth is all this blackness you can see here on x-rays. The more calcium something has, the lighter it will be on x-ray. And so when you look at air, it's completely black. So there's nothing there. So this here are the roots of the teeth. And then this is the crown of the teeth out here. So this black hole at the apex of these teeth, at the bottom of these teeth, is because the body is resorbing the bone to get rid of this infection running out from what used to be the blood supply. So when you see this x-ray, then we can't do a bonded sealant because this is infected, just like a fractured tooth with pulp exposure. This one needs to be either extracted or root canal. Okay. Intrinsic staining or discolored teeth is another thing we see more commonly in older dogs. And again, there's no clinical signs to any of this, but when you see this purple, so what I tell people, purple, yellow, gray, kind of that brown potato color. Okay. This is an intrinsically stained tooth. And the reason that it's stained is that this tooth died. So they're all dead. I mean, and according to the studies, it's 93%, but I have been treating these forever and they're dead. What happens is that this tooth dies and it undergoes inflammation while it's dying. And then the blood is forced out into those dentinal tubules I just talked to you about. So what you're seeing here is a tooth bruise. Okay. And so what we used to do is x-ray them. And if the x-ray was normal, we didn't treat them. We thought, oh, it recovered. Well, that was before 20 years ago when Dr. Hale did a study. Now, if we saw this x-ray again with this infection here at the bottom with this big, wide root canal here, we'd say, yeah, that tooth is dead. If it was normal, they said, oh, it's not. Well, 20 years ago, Dr. Hale published a study, 93% of these are dead. Since that time, 20 years, we've treated thousands of these. They're all dead. So if you look in your dog's mouth and there's a tooth that's purple or gray or brown, it's dead and it needs to be treated. And how do you treat it? Root canal therapy or extraction. Those are the only options that we have to treat that. I talked about that. So oral cancer is an incredibly common thing as pets age. The oral cavity is the fourth most common place to find cancer. And the thing about oral cancer is that it can be incredibly malignant or incredibly benign. And you just don't really know what it is until you have a biopsy. So this dog here presented to me, and it was diagnosed, quote unquote, as a cancer by his family vet. And it's a big tumor running out here. And so the first test that we always do diagnostically is to take an X-ray. And X-rays, benign tumors, like warts, if you will, they don't cause bony destruction. Malignancies tend to, bad tumors do. So the first thing I did is I took an x-ray. And what I could see was there was no loss of bone from this tumor. So I'm like, that probably is a little bit more benign. So when I look at this tumor, I see it growing out rather than in. It's not ulcerative, it's very firm, and there's no bony reaction. So to me, this is going to be a more benign lesion. So this is what it ended up being. It's called, big word, sorry guys, peripheral odontogenic fibroma. It's a wart. It's not even a cancer. It's called a harmatoma, big words again. This is nothing to be worried about. So if I don't see any bony reaction on x-ray, I'm going to trim this back to physiologic margins, back to where it's supposed to be, and biopsy it. If it comes back as a fibroma, I'm going to monitor it. If it comes back quickly, you can take it out. You have to take the tooth out that it's coming from because this is coming from the periodontal ligament. In general, these things grow really slowly, and you can just trim them back once a year. Okay. They can get really nasty. I mean, again, if you're looking at your dog's mouth, you see a big tumor, don't assume that it's a death sentence. They can be treated. And this is, again, that's a fibroma. It's totally benign. It was easily cured. But you can start looking at something that looks like this, where now we're seeing this kind of ulcerative look, and we're seeing all this swelling here. And when we take an x-ray of this, now we're seeing all this bone being gone. See that? All this bone is gone, and these teeth are being moved. So to me, this is the sign of a benign-ish tumor. And it's not truly benign, but this is the classic appearance where it's growing by expansion, kind of like a water balloon. And it's pushing things out of the way, and all the bone is gone. It's all been eaten away. So to me, this is the classic appearance of a tumor called, in big word, sorry again, an acanthomatous ameloblastoma. And it's aggressive locally, as you can see, but it doesn't spread. So this can easily be treated by surgery. Generally, it does require, taking out a little bit of extra tissue, like a half a centimeter. So we would lose the canines in the front part of this jaw, but it's curative the vast majority of time. As a matter of fact, one of our residents is doing a paper on this. I just reviewed it today, as a matter of fact. pretty much every time we've treated one of these, they've been cured. So if your dog has an acanthomatous ameloblastoma, that's what this is called, and you're worried about surgery, don't be. We can cure it. Cancer is actually very curable in dogs. In cats, less. We'll talk about that later. So I here is a cat. This isn't a cat presentation, but here's a cat, and this cat had extractions done a few weeks ago at his family vet, and you can see the extraction site didn't heal. Well, the reason this extraction site didn't heal was because it wasn't gum disease that caused these teeth to be loose. It was cancer, because cancer also eats the bone. So for veterinarians out there or pet owners, if you see a lesion, like if you have a cat or a dog that has really bad area, one quadrant of the mouth is really bad, and the rest of it's pretty healthy, be worried about cancer in an older patient. And this is what the x-ray looks like. As opposed to that all being gone, you can see this kind of starry night appearance. So this is squamous cell carcinoma in a cat, and that's got a really bad prognosis. We can talk about that at another date. Now, the reason I like to put this slide in here, that little bump right there, right? That's just a little tiny bump, not a big deal, right? No, it's just a little gingival enlargement, right? No, that's a melanoma. And melanomas are the one evil. I mean, there's some bad tumors in the mouth, but melanoma is the most evil tumor in a dog's mouth because it does spread like wildfire. And most of the time, 90% by the time you've diagnosed it, they've already spread. So we saw this little growth and we biopsied it. And it was a melanoma. And I came back and did a little surgery and we cured the dog. He lived for 7 more years. So any lump in your dog's mouth should be a concern. And you should alert your veterinarian, and it should be biopsied no matter how benign it looks. Because I'm going to tell you 1% of these totally benign tumors will be malignant. And by early diagnosis, you're going to fix it. Okay. So the last thing, the big thing I'm going to talk about, because the most common thing by far and away, what we deal with, what Stephanie and I deal with every single day is old dogs with advanced gum disease, really severe gum disease. Why? Because we haven't done the maintenance for whatever reason. So I'm going to tell you why. So this is the final part of my lecture. Why you need to treat it, what causes gum disease, how you can treat it, and then why you need to treat it. Then I'll turn it over to Dr. Hahn. So these are normal gingival tissues. They're coral pink in color. There's no plaque. There's no calculus. There's no redness. This is what you want your dog's mouth to look like. This is what you want your mouth to look like. The problem is it took me 2 years to find this dog to put him in this lecture because all dogs have gum disease. Oh, by the way, current studies, 90% of dogs over 1 year of age have gum disease. They all do. And it's this infection that we need to deal with. Normal radiographs, the bone should come right up to the neck of the tooth, should fill up the areas in the bone. I put this in here so you can tell what it looks like later. So the cause of gum disease is plaque. Okay, plaque is the same thing. Gum disease in dogs is the same thing as in people. Plaque is the source of the disease, and plaque is just basically a biofilm of bacteria. It's just a layer of bacteria protected by a little force field, if you will, the plaque biofilm. And really, what it does is it's all bacteria. And the reason that we get it on the teeth is because the teeth don't turn over. We get a nasty biofilm on our hands if we didn't shed our skin all the time. Gum's the same way. But the problem is these things happen. Eventually, it gets calcified by the minerals in saliva to become calculus or tartar. But here's the critical point. Plaque forms on teeth in 24 hours. So I can do a beautiful job cleaning the dog's teeth. But if you're not doing home care for your pets, that infection starts again the next day. Home care is more important than professional care. So I can do a whole presentation on home care. It's critical for your pets. So supragingival plaque, I apologize about the gross pictures, but supragingival plaque is the stuff that you can see on the surface of the teeth. This is the initial plaque formed above the gum line. It can get really thick, really nasty. But here's the critical point. It doesn't do anything for your patient. Or your pet. They did studies in humans, where they removed all of this above the gum and left everything below the gum, zero decrease in inflammation or infection. Vice versa, they left everything above the gum, removed everything below the gum, 100% resolution of disease. So just remember, everything you can see on the surface of the tooth does nothing to your pet. It's the stuff up underneath the gum. So that is why, and we'll talk about this a little bit more in a minute, that's why anesthesia-free dentistry just doesn't work, because they can't clean below the gum. And when you're looking for home care things, you've got to get below the gum. You professionals out there, you need to clean below the gum. That is where the disease happens. So another thing we all believe, and an old wives' tale, is that, well, tartar is the cause of disease, and look for tartar, and the more tartar a dog has, the more disease he has. Wrong. Tartar is ugly. It's a sign that there might be disease, but it's not the cause. The cause is plaque under the gum. So you look at this dog, he's got no tartar on his teeth. His teeth are pretty clean, but he's got horrible inflammation. This dog desperately needs his teeth cleaned. Vice versa. Look at this cat. He's got a huge iceberg of tartar running down his tooth. You physically could not put more tartar on this cat's tooth. Do you see any gingivitis? No. We need to stop looking at the level of tartar to determine if a dog or cat needs a cleaning. Look at inflammation. And then honestly, they need their teeth cleaned every year, as we'll talk about. So you're going to get this question, or as a pet owner, you'll be like, well, I've had dogs my whole life. Why are we seeing this now? I mean, 30, 40, 50 years ago, we didn't have this problem. Well, there's lots of reasons for that. The major reason is, well, there's two main reasons. Number one, our pets are living longer. I mean, for those of you guys that are my age, as old as I am, when I was a kid, if we got a dog out to 8, that was old, right? An 8-year-old dog, a cat was old. Well, nowadays our pets are living forever. And like we said in the teaser, we do 20, 22-year-old patients all the time. 26 is reasonable. So I tell people all the time, 20 is the new 10. I mean, your dog, a 15-year-old small breed dog is not old. And so that just gives periodontal disease longer to affect. The number one reason by like orders of magnitude, little dogs. Labradors, Rottweilers, German Shepherds just don't get gum disease. They do, but minimal. Little dogs, they get it like that. I mean, I do full mouth extractions in 3-year-old small breed dogs all the time. Dogs under 10 pounds they're just prone to it. Why? It's all genetics. Periodontal disease is a genetic disease. Purebreds have worse disease, and commercial pet foods are not good for your pet's teeth. So this is a case in point. These are two Labrador retrievers. Both of them are 12 years old at 12,000 feet backpacking. That's the same lake. That's Gem Lake outside of Mammoth. And they're backpacking at 12. They both live to be 16. So what does periodontal disease do? Well, the first thing it causes is gingivitis. Gingivitis is redness and swelling to the gums, plaque and calculus on the teeth, increased bleeding on probing, and halitosis. Let's look at that. Redness. See that thin red line right there? That little bit of redness right there? That is an infection. If you see this in your pet's mouth, your pet's infected. Low grade, okay, but it is an infection. And if you don't treat it here, what's going to happen? It's going to get worse, right? So another thing about gum disease, which is wrong, and this is why we as veterinarians recommend cleanings every year, no matter what the mouth looks like. Because the earliest stages of gum disease are not identifiable on an awake exam. They're not. End of story. It's not. There's studies that prove it, and we know it. Because if you look at this dog, looks great, right? There's no inflammation. There's tartar on the inside because you can't see the inside. That's the first place that tartar forms. But this looks great. This dog doesn't need a cleaning, does he? Until you touch him. The first sign of gingivitis is bleeding upon probing or brushing. If you've ever flossed your teeth and spit blood into the sink, you have gingivitis. This dog has gingivitis. He needed a cleaning desperately, but he wouldn't have got it from an oral exam. So please clean your dog's teeth on a regular basis. If you don't treat the gingivitis, it proceeds into periodontitis. Periodontitis is inflammation to the deeper supporting structure of the teeth. Now we've got bone loss. Now we've got periodontal ligament formation. And you're either going to be recession, which you can see the roots, or more insidiously, periodontal pocket formation, which is you can't see until you can get the pet under and probe. Ladies and gentlemen, periodontal disease is irreversible. Once the bone is gone, it's gone. There are indications that I can do periodontal surgery and regenerate bone, but it's not very common. So what I tell clients and vets all the time, periodontal disease is 100% preventable. It's 0% treatable. We've got to do a better job of prevention because now we've got a little bit of recession. Now we've got a little bit of bone loss. I can work with this. We can clean this and save these teeth. But the problem is so often, and this is Stephanie and I's like bread and butter. This is what we do every day, are dogs that look like this. And it's because we haven't taken care of these teeth before. So it just gets worse and worse and worse. And now we've got all this infection, and now we have to extract these teeth. And oh yes, your dog will do just fine without any teeth. But again, it's not ideal. We want to save teeth, and we don't want to have this dog through all this pain and infection for years to get there. Okay. So Really quick, I'm just going to run through some other reasons that you really should be taking care of your dog's teeth, especially small breed dogs, because there's lots of consequences beyond just bad breath and tooth loss. The regional consequences are what's called an oronasal fistula, which is where the infection breaks into the nasal cavity because their roots are so long in small breed dogs. Class 2 periwindo abscesses are where the infection gets in through what used to be the blood supply. Eye loss. Pathologic fractures, jaw fractures, increased risk of oral cancer and osteomyelitis. All these are really well known. So this is an oronasal fistula, most common in dachshunds, but it can happen in any small breed dog. Look at the teeth. The teeth don't look too bad, but look at where that probe's sitting. It's into his nose. This dog has a chronic nasal infection. This client spent about 20,000 or now about $10,000 working up why their dog had chronic right-sided nasal discharge. It was an oronasal fistula. Eye issues. This is not an abscess. This is its dog's eye juice. His dog's eye popped and it's draining out. Why? Well, here's the eye bone. So this is that bone right below your eyeball right here. It's called the zygomatic arch. This is the globe. So this is your eyeball. This is that first molar. See this blackness around that root tip? There's no bone between the root tip of this upper first molar and the eyeball. Dogs lose their eye from gum disease not infrequently. Oh, by the way, there's an ophthalmologist that I gave this lecture to. He said that the vast majority of orbital disease, the area around the eye that we see in dogs, is dental related. So if you got chronic eye problems, take care of the teeth. This is a class 2 periwindo lesion. That's what I talked about. The infections come down here, got nipped through what used to be the blood supply, come up over here and caused infection there. This is what's called a fibrous union. It's not broken yet, but it really, really wants to. And then this is a pathologic fracture waiting to happen. And again, we only see this in small breed dogs because large breed dogs, I don't know if I have that slide in here. No, I don't. Large breed dogs have their roots are much shorter in relation to their jaw. So a large breed dog, if you have a Labrador, don't worry about breaking the jaw of a from the lower first molar or the big chewing tooth on the bottom. What I tell people is if you got a dog under 10 pounds, you have to be afraid of it. If you have a dog under 5 pounds, you have to be very afraid of it because this is normal. It's normally less than a millimeter, and this is 0.3 millimeters. So if you have a small breed dog, you really have to be worried about jaw fracture as well, and that's what a jaw fracture looks like. And they're really hard to fix. We can fix them, but they're hard. Oral cancer, increased risk of oral cancer on the human side, and then osteomyelitis. This whole mandible, you can see all this reactive area here. This whole mandible is dead. We had to take out the whole jaw. Why? Gum disease. And these are mostly small breed dogs, anything under 10 pounds. So when it comes to talking to doing this, you need to take care of these patients. And those are the local consequences, but there's systemic consequences too. I'm writing the second edition of the periodontology book. Thousands of studies, mostly human, but thousands of studies because you get this inflammation in the mouth and that redness of the gums allows the bacteria and their byproducts to get throughout the entire body and it negatively affects all over the place. So in humans, dogs and cats, the heart's affected. You can have endocarditis or infection of the heart valves. The number one cause of chronic kidney disease in cats is kidney disease. Okay. Same in people, or not same in people, but also seen in people and dogs. Liver disease in people and dogs. Increased inflammatory markers. Everyone's heard of C-reactive protein. Markedly elevated in dogs and cats with periodontal disease, and canine cognitive dysfunction and Alzheimer's in people, strongly correlated to periodontal disease. In humans, they also see arthritis. Diabetes mellitus is a massive one. This is probably the best studied thing on the human side, is the relationship between diabetes and periodontal disease. Pulmonary disease, there's no studies on the humans on the veterinary side. Don't ask me for one. Well, maybe eventually, but there's no studies on the veterinary side that show that dogs with good oral health live longer than dogs without, but there are on the human side. And so, oh, by the way, if you've got a dog with heart, lung, liver, kidney disease and a bad mouth, and you treat the heart, lung, liver, kidney disease, those things get better. They improve. Most of these are human things, but it's been shown in cats with kidneys. It's been shown in inflammatory markers and canine cognitive dysfunction. There is a benefit because they don't have to fight that infection anymore. So when your dog, I tell people all the time, when your dog gets a little bit sick or your cat, don't stop treating the teeth. That way, when they get really sick, you don't have to treat the teeth. And I'm going to lead into Dr. Hahn's lecture right now that there is no such thing as a pet that's too old for anesthesia. Age is not a disease. It's a natural consequence of not dying. Like I said before, we do pets in their 20s all the time and they do great. You just need to work them up and have someone that's comfortable with the anesthesia, who is Dr. Hahn. Dr. Stephanie Hahn is a board certified anesthesiologist. She travels around the country actually providing anesthesia care for pets all over the place. And she's who's been working with for about the last year. So she's going to talk to y'all about how we can do anesthesia for your pets. And I'm going to leave you there and come back for questions in a little while.
Okay, taking over from Brooke. Dr. Niemiec, thank you. All right, we are a group of board certified anesthesiologists and board certified technicians and a support team that partner with Dr. Niemiec to provide the anesthesia care that parallels all of the dental work that he just went over. So we really have to work in concert with each other. If you want to check us out, you can. We have a website, anesthesiablack.com. And I would start with this is a really common slide to see in many anesthesia lectures, but there's a quote from a human physician in pediatrics that said there's no safe anesthetic agent, there's no safe anesthetic procedure, there's only safe anesthetists, which is really just like an expansive comment on I can give you an anesthesia protocol, but how
Yeah,
you apply that.
I don't see your slides yet.
Can anyone say in the chat whether they see it? It's saying I'm share slides, but okay. All right, great. If the audience is seeing it, then I'm gonna keep on going. Thanks,
Okay.
guys. Okay, so there's somewhat of an art to this, right? Like it's different from radiology. I can send you a report on radiology and the abdomen and what there is in a long description, and that might be enough for you to apply that to your case. But I can't just tell you a drug. You have to kind of know how to use that and when to use it and um, all of the judgment calls that go along with what is going to happen in the course of the anesthesia procedure. So we have a whole team. We believe in team-based care. And if you look at the bottom of this, who is the anesthesia care team? The primary service veterinarian is part of that anesthesia care team. So Dr. Niemiec, as much as he wants to focus on the dental, he's part of our anesthesia care team. Okay? We have to work together. I need to take all of the information that Dr. Niemiec just said. Is this very urgent to do? And collectively, yes, right? I might have comorbidities or I might have things that are wrong with my older patients, but if I get the dental work done, if I help carry them through their procedure, these comorbidities can get better over time, right? So I'm helping Dr. Niemiec to get the dentistry done. He's helping me to provide all the information I need to know to keep that pet safe during the procedure. So it's anesthesiologists, it's specialty technicians, it's our regular technicians on the floor and the dental care team, it's our assistants that are helping us to be efficient, and then it's also our primary service that's working all together, okay? Well, we're really having a hard time with screen share right now.
There you go.
Can we still see it? Okay, so what does that mean? You guys get to interface with the dental team in your consults, but you might not get to see us. We're kind of back of house. So I just wanted to give you a sense of when you're working with an anesthesiologist, what does that mean? Well, we went to the 4 years of vet school. We did 1 or 2 intern years. So that's post veterinary school. And then we did a 3 year long residency. And if you look at the world, at the time that we originally wrote this data, which might be a couple of years old now, there were around 300 boarded anesthesiologists in the US and 200 in Europe. So there's only 500 of us in the world, right? So it used to be that this care was really siloed in our bigger universities or larger referral practices. And now that we have some more travel and then remote-based tools, we're able to give this tiered option to our owners out in many places in private practice. Okay, so what does that mean, boarded technicians? So boarded anesthesiologists we just talked about, but we also have nursing staff that has done many years, like they have to do about 5 years to even qualify to sit their boards, and they do a board exam as well, and our group can go around and either run cases or do the anesthesia or provide training to provide other support. Dr. Niemiec has a VTS nurse on his permanent staff as well. So if you can look for these words at your consult times, you know that that practice, VDS has put in some significant thought to the anesthesia care team that they are building, right? So we can provide education, we can do training, but we're also getting called to run our more complex procedures in person or on site, right? And that's kind of what I'm doing mostly with Dr. Niemiec when we work together. And he showed a picture of his old dog. I'm showing a picture of my old dog. So Nikki, my husky, when she was 2, is going to be a very vibrant, healthy patient to deal with under anesthesia. Probably appropriate for her care to be done in many different settings, right? But as she gets older, we can see some things just by looking at her. She's a little more muscle wasted. She's probably a little bit weaker. I have to be careful about how I position her. She might be a little bit less tolerant to larger drug dosages. So we had a question about MDR mutant dogs that we can talk about a little bit later. So yes, we're seeing a lot of small breed dogs, but we're also seeing our geriatric larger breed dogs as well. They come with different things that we have to be careful of. So, it's not uncommon that if we're not careful about positioning, we can have an exacerbation of our osteoarthritis, right? You or I, if we are in our 40s, 50s, 60s, if you had us sit in one particular position with no muscle tone on our own to keep ourselves comfortable, and we sat in that position for hours and then got up, even if we were under anesthesia, we'll be sore the next day. So all of these nuances of care we have to bring to these patients. And then also, why are we muscle wasted? It is because we have some underlying disease processes going on. Are our kidneys functioning well? Is our heart functioning well? So in our preparation of these cases, we're going to do a holistic look at your pet and try to get all of the information we need to make a good protocol for them and good management strategy. So this is a paper that I just pulled to show you about life expectancy. Dr. Niemiec was talking about this in his lecture as well. Okay, so I just pulled, I'm not going to be too technical here, right? But I just wanted you to see one figure out of this paper. It was a really large data set in the US, about 9 million dogs and 2.5 million cats. And as we look out to our age, so this is the pets that are still with us after 17. If you can just make out the colors here, this is kind of what Dr. Niemiec was alluding to about the caseload that we're seeing. It's a lot of toy and small breed dogs. The medium, large dogs have kind of fallen off, right? The blue and green are not present as much. And then our cats are also in this population. So we didn't talk a lot about cats, either of us, but if you look at the numbers, there were 27,000 dogs in the 17 plus category. We could get in the nitty gritty of what that stat actually means, but just the category presented at large, there were 26,000 for dogs and 60,000 for cats. So, it's a great visual representation. This was a paper I think out of 2023 that our pets are living longer, right? We need to support their oral health through a longer age period than we used to. So how can you be a part of your pet's anesthesia care team? And I would argue you're one of the most important parts of this care team because you live with your pet every day and you've seen the history more than anyone else. Even if you adopted them recently, you know more from having lived the life with your pet than we are going to know from reading a paper about them. So I can't stress enough how helpful it is for you to bring a thorough story of your pet to your appointment. Right, you can tell us their history, what medical problems they've had. You can have collated their records as organized as you can, or you can get us your primary veterinarian's contact information so that we can look at those records and have that conversation. And as Dr. Niemiec was talking about, our routine oral health, our routine systemic health, that's really important to set us up for good anesthesia care. Okay, if we have had serial blood work through our life, that's going to be really helpful for me to tell what's going on with your pet at today. The same thing as if you have cardiac disease starting, having serial rechecks with the cardiologist is going to give me more information so I can keep track of them. All right, I told Lydia that I would talk about MDR. So having the genetic testing done, having notes from previous anesthetic management, and how those recoveries were, how sensitive they were to certain drugs if they've been challenged with them, that information can be very, very helpful for us in the anesthetic that we're going to do today. Okay, so setting a protocol, there's this theme out in the world that like I'm going to set protocols and that's going to be what I use for this type of procedure or this type of patient. And we really steer away from doing that. We want to look at each patient case by case. We want to look at their particular history and their particular things that they have going on with them and build a unique protocol and management strategy. Okay, so this is a great quote that I love, that setting yourself on a predetermined course when you don't know the waters is a great way to head into an iceberg. So, how do we make sure we're not going to have an adverse event in transit of anesthesia? Well, we're going to give ourselves all of the tools, all of the diagnostics, all of the history to be able to chart a path for your patient. So our pre-anesthetic evaluation is really, really important. Our goal is to assess how ready are we for anesthesia that day. So when you come to your consult, your dentist is going to talk to you about, have you ever heard a murmur? Do you have any history of seizures? And we're going to go through a history just like you or I would at a medical appointment, okay? We're trying to identify, the more information you give us, we're trying to identify areas of risk for your pet. And then based on that, we're going to assess in the consult, are there any other diagnostics or treatments that we might be able to do to make that risk lower? And the answer might be no. The answer might be, well, there's some risk, but this is as least risky as I can make this pet today. And the answer might be, yeah, I can do more. I have heard a murmur. No one's ever talked about this murmur before. I can potentially go to a cardiologist and see what's going on more in depth with the heart, get on treatments for that, and come back at a day when my risk is lower. Okay? In the face of that, we have obviously constraints, right? We have practical constraints, that's always possible, but it's our job to inform you what your risk is. So even if we choose to go forward, we're going to do that knowing that that risk is present, okay? So what is comprised in the pre-anesthetic evaluation? We have a history that we talked about you could bring in your owner interview at the consult, the primary vet records, or our physical exam that day. You might have a consult with Dr. Niemiec months before I have your procedure, so I'm going to repeat that physical exam when I see your pet to make sure that nothing's changed. Okay, we're going to ask for some diagnostics, so full blood work, and then potentially some additional depending on what the risk factors are for your patient. And based on our findings from those two, then we might ask for some more, like maybe some imaging. So we might look at the inside of the chest or the heart or the kidneys specifically. And we're going to harp on those because those are really common issues that we see. Okay, so ASA status is something in anesthesia that is a classification, a categorization. And we go from 1 to 5. It's the same in people. And it's basically trying to tell you the fitness of that patient for anesthesia today. It has nothing to do with the procedure. So Dr. Niemiec could have to do something really complex or really short. We just had a patient with Dr. Furman at a different location. The procedure is very short. The ASA status for the patient might be high. So they're two separate concepts. But what it tells us is how difficult or how fit is this patient for anesthesia that day. So look at number 1 would be like a normal healthy. My husky at age 2 was an ASA 1 case, okay? My husky at end of life was more of an ASA 3. So as we start to have kidney disease, liver disease, diabetes, etc. Maybe we have a dog that has airway abnormalities normally, then our number starts to go up. Does that change whether we can do anesthesia? No, but it does give us a roadmap for what we have to do to keep them safe if we are going to say we need anesthesia. So how do we help with that when we partner with Dr. Niemiec? We'll collate all those records. We'll look through them as a team. So it's not just me looking through them. It's a group of nursing staff that are all anesthesia trained and have been working for, 5+ years in the field, and myself and another anesthesiologist, as that's who's working on the case. And we're going to write up a summary of the patient's status. Okay, so you can look in like the past pertinent medical history, and we're going to highlight so that everybody on the anesthesia care team, which includes the dentist, knows what our past pertinent medical history is, what our current diagnostics, so what were the blood work findings. This is pro-BNP. It's another blood work item that tells us about your heart and whether your heart is close to failing or not. It's going to list any current medications that your pet is on, because we might need to tell you to stop those, or if they're continued, we need to know how they're going to affect the anesthesia and what concerns we have for your patient. All right, so here's an example, just scrubbed of personal data, but this is a cat, and we have very common issues going on with this cat. We have HCM, which is a cardiac disease, a heart disease. We have kidney disease. Those two are managed oppositely, so it's really important that we know that they have these competing problems, because we give fluids aggressively to one and we restrict fluids from the other sometimes. So if I don't know details about what this disease process looks like for this pet, I won't know how to manage them correctly. Okay. Also, this cat had hyperthyroid, so we have some endocrine disorders that can play in. If the hyperthyroid's not controlled, that's going to exacerbate the heart disease. So this kind of shows you, like, well, how did we get to, you go for your consult and it's really frustrating. You want to get in for your dental, but we're asking you to do all these other things. And I think about it like this. You get on a plane, you expect the plane's going to land. But why do we have that expectation? Because there are checklists, because we give our pilot every tool provided, that we make sure the environment is clear for them to have a good runway experience, right? So the less of these I get, the higher the percentage the plane's not going to land. Does that make sense? We want to have all of the information possible so that we can make a great decision and have great care during. So it's not that our older patients always have these, right? Old doesn't necessarily mean more difficult, but old can potentially come with more of these. And the more comorbidities I have, then I have to be more careful, right? The ASA is now 3 instead of 1. Okay, that's not from age, that's from the disease processes that they have potentially at that age. So what are the lab works that we're asking you for? Everyone's going to get comprehensive lab work within a reasonable time frame of your procedure, so that we can do things like screen for things that are wrong. Maybe you haven't had recent blood work, or maybe there's been a change in the last year. So we want to catch that before you come to your procedure, because the anesthesia could make these things worse, or we could find something that might be needed to be treated first. Okay. The extra off of the comprehensive blood work in the first line, these extra items we might ask. So let's say your patient has some liver dysfunction, then we might ask for things like bile acids to be tested so we can quantify that or characterize that liver problem. And sometimes that means we're saying, hey, I think you should see your regular vet again, or I think you should see an internal medicine specialist, because they're going to get your pet under control first before they come for this anesthesia. And even if you've already known that you have the pathology going on, having serial trends over time can tell me a lot. It can tell me, well, is your kidney disease worsening? Then we don't want to add anesthesia on top of it. When the kidney disease is getting better or stable, then maybe we can continue on, right? And we can take on this risk. But that's the point, is like, we want to take on that risk intentionally. We can never bring the risk to 0, but I want to make the best informed decision I can. And then blood work the day of is always going to happen. These are called quick assessment tests. Why did I get my CBC Chem 2 months ago and I still have to get blood work that day? Well, your hydration status each day changes. Each 4 hours could change. So we want to make sure that your patient, your animal came in hydrated that day. that we kept them off of food, but they had enough energy, glucose level to be all right. Okay, so these tests we do every patient every time, and that's very normal. That's what would happen for you or me in the hospital, and we would be able to guide our fluid therapy with that. Okay, one really common thing that we see, and Angela just commented about her 20-year-old Chihuahua that we got to see had a heart murmur, right? So this is exactly this case, right? Heart disease, we see murmurs all the time. The referring vet or primary vet that you see is the best help for us to screen these. When we see a murmur, we can't just stop there because look at this list that I've compiled, and this is a short list. Let's say 80% of our patients are in these top 3 category that we see. But I don't know off of the murmur which one it is. I can tell you statistical probability, but I will say that treating mitral valve disease and treating HCM are really different. The protocols are completely opposite. So I have to know what disease I'm working with to be able to make a good decision, all right? And you might get an ECG, which tells you about the electrical activity of the heart, and we might ask for an echo, which is going to give me a picture of what the heart looks like. It's going to tell me about the flow rate through the heart and how hard the heart can pump. So this is another specialty practice that we work at, but it's a great image to show you. This is the ECG that you get at your consult. It tells you electrical activity. We can use it to screen for things, but look above here. Does this tell you at all what the heart looks like? Not really, very sensitively. So when you go to the cardiologist, they take a look with an ultrasound machine, like you would check on a baby at a pregnancy. They're going to look at your heart and see the inside looks good, the wall thickness looks good, the flow looks good. And if it doesn't, they're going to consult with me and they're going to let me know what's going on so that I can tailor the drugs, okay? So this is the ECG, this is the echo. The echo is the gold standard of what we need for these heart disease patients, and that allows us to have a good experience like what Angela is saying in the chat. Many of our heart disease patients come on a lot of drugs. And some of those drugs we want to have on board, and some of those drugs we don't want to have on board. So if you are on an ACE inhibitor, renin-angiotensin blocker, those are meant to keep the blood pressure down. We want that every day of the dog's life, except for the day that we have anesthesia. Then we might withhold that. So it's important for me to know all that information so that I can tell you to withhold those drugs. All right, so we also see kidney disease at a high incidence. We can catch this usually on blood work. And if you see, these are some of the values that we might get in your blood work to tell us, oh, this is a little high, you know. What we want to do is either confirm that you've been in care and it's been static and not getting worse, or if we screen it and it's new, we're probably going to say, hey, I think it'd be better if you go back to your regular vet or you go to an internist because they can treat this. I don't have to put anesthesia on top of this. You can get anesthesia, and we will take your dog to anesthesia, and we'll take care of the dental care, but my job is to say, is there anything that I could do to make this safer for your pet? And if that answer is yes, I'm going to offer that to you and then book you at a little bit of a later appointment time. Okay, so this gets staged, and the stage can tell us risk factors, prognosis, and whether we're stably being treated or not. So this is a sort of kind of more of a lay article out that you could find. And I just wanted to pull, why would I send you? Why can't I just look at the blood work and treat that? Well, I might send you to an internist because they are going to look the same way we looked at the heart. They can look at the kidneys. So this is pulled from that paper, but this is sort of like a normal kidney image on the right. And this is a kidney image on the left that has some significant change to it. So that might be really helpful for us to be able to see the kidneys to decide how we're going to get them treated. And you don't necessarily want your dentist treating your kidney disease, right? We want to send you to the kidney person, the internist, your regular vet, and get you on good management and have that partnership so that we can take you back and get your dental care worked out, which in turn may help the kidney disease. So again, we might come on some drugs that we need to withhold. So it's important for us to see that records as well. All right, why do we care about this? Because this is from a human paper, but we had 3 cohorts of patients they looked back at, and I'm just very briefly summarizing these results. But these are patients that had no kidney injury. These are ones that had like mild kidney injury prior, and these are ones that already had significant kidney injury before anesthesia. All right, so this guy that had moderate to severe injury after it already came in with moderate to severe injury, that's not happy, but we're not surprised, right? We want to avoid, especially this guy that came in with no kidney insult that we knew of and left with moderate to severe injury, right? That one's going to be a big heartbreaker. Or the majority of our patients that were in early stage kidney disease and we exacerbate that because we're not flying with all of our information. Okay, what is great about our partnership is that if I worked in dental practice only, I wouldn't be able to synthesize all of the things that happen in anesthesia world at large, right? We also go to these larger referral centers, so we interface with nephrology, we interface with surgical oncology. So I can give you some insight on, well, why do I need full blood work? I will tell you, when I work with the surgical oncologist, a lot of their patients are there with neoplasia because they were screened at their dental appointment, and so we were able to get that taken care of and have a safe dental procedure afterwards. Okay, so what are our options for care? Even in human medicine, we're utilizing telemedicine more and more. So we're able to get to more places and we have a very full-time partnership with VDS because we can have a remote care, we can have electronic medical records that we access, right? So we can do this consult virtually, walk someone through how to do the anesthesia. We don't just send a protocol and then let you fly. We talk about the underlying heart disease. So you can see when we put together this presentation, we're going back over what's happening in the dog. When you use these drugs, how do you have to use them? Okay, we can also do remote case management. So this is not at the San Diego location, but the Irvine location, and we can be on with the anesthetist throughout the whole procedure, okay, from start to finish, from initial drugs to recovery, and we're just remote backup. And we can also be on site managing. This is a nurse that deployed for me, and then I'm remote monitoring with her. And then I can also come and do the procedure myself, which is what Brooke and I spend a lot of time together, for better or for worse, from Brooke's vantage point. So, all right, that's a really large, broad topic of how do we manage our geriatric care in specialty dental practice, but I think happy to take any questions from you guys at this point.
I think, Stephanie, that your Nina had a question that I think you're
Okay.
better at to answer than I am.
Okay, how does the stress of going to the specialist factor in as far as health impact? That's a really insightful question that even I think in the veterinary community we have to remind ourselves. The drugs and their impact can be the same as stress and the impact of stress. So, what does stress do? It causes sympathetic tone increase. It can increase your blood pressure. It can have a lot of cardiac effects that have downstream, effects on your kidneys, etc. So, if you've ever, any of the nurses have this work with me, I'm very pro, let's have a calm experience for the pet. Um, we can use some oral medications before you even come in. If your dog or cat is high anxiety, or really any pet could have these, but especially the ones that are high anxiety, they can have oral medications before they come. We use low stress handling techniques, so especially with our cats, there are particular ways to put them in, restraint that are not very physically demanding on them, that sort of align with their behavioral ethogram more. We can use quiet spaces, low lighting. We can use soft handling. We can use techniques that allow them to not feel their catheter placement. And then our drug protocols can really impact whether they have a dysphoric recovery from anesthesia. So meaning, do they wake up calmly or do they wake up really excited? So we do think about that everywhere along the way. And sometimes, we tweak it over time. You make your best judgment on how we can guide them through their care today. But another thing that's really important is we'll write notes in our anesthesia record as to how that sedation was, how they did at their catheter replacement. That behavioral note is really important for the next time that we see them. Do you want to tackle Brooke Betty Chihuahua's question? I'm happy to also tackle. Up to you.
No, yeah. So, no, I mean, there's not, I guess it really depends on a lot of situations. I mean, a lot of vets do a great job cleaning the teeth. And it really depends on does your dog have a severe dental problem or does your dog have a severe anesthetic problem? I will tell you as a specialist, I know, I tell people this all the time, why I partner with an anesthesiologist is I know how much more about dentistry than I know than a general practitioner. And that's how much more she knows than I know about anesthesia. So I'm a good anesthetist, but I'm not an anesthesiologist. So, if your dog's healthy and doesn't have bad disease, I'm sure your regular vet can take care of it. If they get into advanced disease, or especially if it's a small dog and you're worried about jaw fractures, or it's especially if it's advanced, I mean, we're pretty quick, so we can get it done faster. Like, we didn't talk about the length of anesthesia time. But shorter anesthetics are better. So if we're faster, if we have an anesthesiologist involved, and it doesn't to say there's a lot of GPs that work with anesthesiologists as well. So that's certainly an option as well. But I mean, no, to say no, I mean, we do have a lot of clients who just come to us because they're specialists, but it doesn't mean that you can't go.
I think the longer look at that is we have to look at those. Brooke kind of just touched on it. We have to look at them as separate things. Like, is the dental care needing advanced specialty care? Is the anesthesia needing advanced specialty care? A lot of times those go together.
Right.
And so that's why Brooke and I work together all the time. But it's possible that you have a really, like, if I just have to biopsy one place, the anesthesia can be very complex and the biopsy itself could be something really not tricky. And in reverse, Brooke could have some really tricky extractions and it's on a relatively systemically healthy animal. Like the 3-year-old that you talked about that you did full mouth probably wasn't the most complex anesthesia. But is there always a benefit to having a specialist? There's probably always a benefit to that, and it's risks versus rewards. There are not many of us, right? We have only 500 of us in the world, so we couldn't possibly do all of the anesthesia under anesthesiologist guidance. It's
Same
about
thing with
having,
dentistry.
yeah.
Same with dentistry. Yeah, there's less of us. So yeah.
So that partner relationship's really important. The anesthesia care team includes the primary vet because I need to have a conversation with them about, is this something that should go with you? Is this something that should go with me? Is this something that can go with you with my guidance? And Brooke has that same relationship. It's not an either or really. It's working as a team and then where do we put these cases together?
And to answer the question about are there ever cases that are too sick for anesthesia or the risk benefit ratio is out of whack? And yeah, there are some. I would say that Stephanie would probably agree with something like sick sinus syndrome
Yeah, it's a
would
good
be
example.
one. Insulinoma would be another. A dog in fulminant heart failure that needs oxygen supplementation, would be another. So there are dogs, and again, a little bit of that also depends on how bad is the dental disease.
Yeah,
If I mean,
bingo.
because what happens to us, and this is why we work together so often, is that, like I said at the end of my lecture, animals get a little bit sick, and then everyone goes, "Oh, no, 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 no more anesthesia. You always got a heart murmur. Oh, no more anesthesia." And, back 20 years ago, a dog that developed a heart murmur, got into stage 2 kidney disease, didn't live very long. Well, now they're living for decades
Right,
sometimes. And so the problem is that you take these dogs and you stop treating their teeth, and every year the heart gets worse, the kidneys get worse, the mouth gets worse. And so then it ends up with abscesses and broken jaws and all these things that we have to do. So the answer is, yeah, one in a million, probably. One in a million, probably the risk benefit ratio is too high.
Wendy,
Um,
sometimes it's about what does your place have the capability of doing? Dr. Niemiec's group puts in a lot of investment effort into, like, I have equipment that's great. I have monitoring that's advanced. So what I can tell that can go in Dr. Niemiec's facility is more than what can go somewhere that doesn't have that access. And the sick sinus syndrome is a great example of, well, we're never going to have a cardiologist that can put in a pacemaker at dentistry practice. So that case might need to go somewhere else. And that's the anesthesiology dental partnership, is for him to say, I have to do this. The dog's jaw's broken. We don't have a choice today. And for me to say, well, it can't go here because we don't have what we need, or it can go here as long as we understand the risks.
Um, Stephanie, anything about anaphylactics?
So anaphylaxis can happen with any drug, anytime. There's some that are particular triggers, like antibiotics can be, contrast can be. So when we're doing CT, if we're using contrast, and then we are trained to be able to recognize that, and you would use some combination of steroid, epinephrine, the same drugs that we use in human medicine. And we can also, if we know that they have anaphylaxis, we can pre-treat them if they're particularly sensitive. The MDR Kali, yeah, we do oftentimes use this drug recommendation. So there's literature out that shows what collies with MDR or other breeds that have an MDR mutation are sensitive to, and we will try to use low dosages of those or modify our protocol so that we don't need them. The one thing I would say, Lydia, is that at least with dental work, we have a great ability to do local blocks where they can't feel their face as much. And so we can avoid one of the heavy hitters, which is a high opioid dose.
And as far as if you're talking sea kelp, if you're talking about plaque off, yes, I do believe that plaque off is an effective way as a food additive. There's so many products out there; it'd be really hard to like list them. Probably the best way to find the list of appropriate dental treats is the Veterinary Oral Health Council, the VOHC. So if you go to vohc.org, it'll list all the products that have approval by a group of veterinary dentists for efficacy. There are products that don't have that are effective, but I think you'll have a very good chance of that being a safe and effective product if it's on the VOHC.
All right, difference in anesthesia gases. There are differences. So there's gases that we use, so mostly oxygen, but you can use other gases. We don't use nitrous as commonly in animals as they do in people because the way that they're sensitive is different. Like dogs are not as sensitive to it. So we wouldn't really have access to that in most places unless you're in a university, and it's even pretty rare there. But we have ISO and SIVO, which are anesthetic vapors that are very common, and there's some minute differences between the two. There are some cases where I would prefer SIVO over ISO, but honestly, you could tailor a protocol to using either.
Um, And then, Lydia, some dental gels powders are effective. Again, you've got to look for research. There's so many. If you're on Instagram, those of you guys that are listening on Instagram, there's so much junk out there that has zero scientific evidence that it does anything. People come to me with stuff all the time. It's like, oh, I got this off the internet. And I'm like, yeah, there's no scientific basis that it does anything. Even if it says, freshens blah blah blah. There, you have to look for a study. And again, that for veterinarians, I recommend going and actually looking and seeing if they actually have studies that are published. But for pet parents and for vets that don't want to spend that much time, the VOHC is the best thing. I will talk a little bit about the unrelated procedures, multiple procedures at the same time. That has gone back and forth over the decades that I've been a veterinary dentist about whether you should do them or should not do them. I think currently, because of what we know about bacteremias being released by the body every day, being, with eating and brushing teeth and all that kind of stuff, we worry less about the bacteremia, for tumor removals and things like that. And so, from that standpoint, I don't think that it's a hard no anymore like it was. My personal opinion is, things like small lumps, things like lacerations, abscesses, I think those are absolutely fine to do at the same time as a dentistry. Um, I personally would not enter body cavity, and that would include a spay. I wouldn't do that or any type of body cavity. Plus, those are pretty invasive procedures for the most part. And I think the other thing we didn't talk about today, I mentioned it a little bit, is time under anesthesia. And really, for years and years and years, everyone was like, "Oh, we don't want to anesthetize them more than once." But I think there's enough current research now, and Stephanie, correct me if I'm wrong, that two short anesthesias are safer than one long one, especially after you get over 2 to 3 hours. 3 hours, I was just reading a paper. 3 hours is kind of like the magic number, and we have anecdotally found that the long procedures are the ones that we tend to have complications. So we generally try to keep procedures under 2 to 2.5 hours. Occasionally they'll go longer, but if you have just a quick thing to do, then great. If it's going to be two big procedures, then I would split them up. Stephanie?
I would echo that. I think the literature is starting to look at that. I do strongly feel anecdotally, so this is just our experience together, that I work in a lot of different places, and Brook Niemiec's practice is very fast. So I can get away with some things in the anesthesia side that I wouldn't if it was going to be a longer procedure. So, and that, yeah, I would say, this is all just experience, but it is with the heart disease patients, especially at like 2 or 3 hours, it becomes a little bit more challenging for them to kind of like maintain themselves under anesthesia, and I have to do a lot more support. If it's something we had to do, could you do it? Yeah, these cases go a lot longer all the time. But would I elect to do that? No, I wouldn't.
Take on the
Um,
CKD.
yeah, CKD. So a large majority of the cases we're seeing are stable stage 2. I would say I haven't looked at the numbers. It's got to be like 80%, 90% of what we see for CKD is in that realm. There's a lot out there that is about, CKD can be managed at that if we're cognizant that they are eating and drinking well, that they're hydrated, that we keep their blood pressure at a good level during anesthesia, then we shouldn't have to avoid anesthesia for these cases. Stage 3 starts to be a little bit more difficult. We need to check some more things. Like, is it a hard no? Like, none of these things are hard no's, I would say, right? If the dog presents with a broken jaw because it fell off the bed and it had this pathologic fracture, what can we do? We can't just leave them with the broken jaw. So we may have to take on that risk. Would I do that for a 6 month cohat? I don't know that that's the choice that I would make. I mean, this has to be in a partnership with Dr. Niemiec's advice, right? But stage 3, and I'm thinking we have to look at our electrolytes that day. We have to look at the medications you're on, and we need to talk to you about it. Might be a higher risk, and we should have a plan for you to go after the dental work to get check-ins with your regular vet, and just have a plan for that, right? So is it a hard no? No. But will I manage that case very differently? Yes.
And we need to make sure that that pet is eating and drinking, and post-operatively from dentistry, they may not for a couple of days, especially cats. So I would say that that's probably the number one thing in our discharges that we tell the clients is like, especially if an animal that has, kidney disease, is like this pet needs to be eating and drinking. If they're not eating and drinking within 24 hours, you need to go get checked out. That's the big thing.
Right. So, our older pets can do fine. Many, many of them do fine. The thing that I would say is that they don't have as much reserve. So when they don't do fine, we need to see that early. We need to support that early. And so, we can do this in outpatient care as long as we have a plan for, well, if your pet needs that extra care, do we have a conversation already with your regular vet or urgent care? Okay.
Want to talk about Kate and brain fog?
Cognitive dysfunction is really a emerging research topic. They just published like a review on a description of the disease process and how we recognize it, how we treat it. So it's also a very legitimate concern on the human side that is discussed all the time and doesn't have black and white treatment parameters for it. I would say we can keep things short. We can avoid high dosages of drugs. We can avoid some of the more like dysphoric causing medications. So they just published in Human Medicine that I'm using a little bit of a sedative that some people are afraid of using. So using dexmedetomidine can be helpful for support of cognitive dysfunction, because if they emerge with delirium or they emerge very excited, that can correlate to cognitive dysfunction later. Again, this is like a new paper, so I think what you'll find is in 5 years we'll have a better answer for you. It is a concern. It can get exacerbated. We do our best to avoid that. Most of them are going to take, a few more days. Like if they're at that age with those comorbidities, they just might take a few days to bounce back from their anesthesia as well. But it's something you have to be aware of.
And malignant hyperthermia?
Um, okay, did we want to say there was the anxiety, skittish anxiety one, right?
Yeah.
Um, that
Well,
might be a you.
yeah, so basically, I'm seeing a lot of questions about food. There's one food that I just love, and it's not because I get paid to say this, but because I've done the studies on it, and we could talk about this in a future one if Stephanie wanted and I want to do something again. There's a product, my favorite, like yeah, brushing's always going to be the best, but my favorite beyond orders of magnitude, if I'm going to pick one dental treat for a dog or a cat, it's going to be TD. So TD, tooth diet from Hill's Pet Nutrition. If your dog or cat doesn't have any other medical issues like kidney disease or liver disease or allergies or whatever, if they're an overall healthy pet, I believe that every pet over a year of age that doesn't have any other issues should be on TD. And it was the number one maintenance diet in Canada for years. So it's a totally good diet. It works really well. So if you want to treat your dog with what's called passive home care, TD's number one. I do like greenies. They're fine. The Oravet Dental Hygiene Chew, which your vet might have, is a great one too. Rawhides work. Plaque off, like we talked about. Not a huge believer in water additives, but those are the diets that I tend to really like on that one.
Wendy, dogs, all species can get hyperthermia, but this is not a very common presentation in our dog cat species. Pigs, incidentally, are very well known for malignant hyperthermia, and places that do a high pig caseload will carry an IV formulation of the drug that will combat that. The problem with carrying it for a very low incidence of dogs, cats is that it oftentimes expires before it's in use. So it's like really hard to actually have it be in date for a rarity. And let's say I've been doing this since 2016 in some way, shape, or form, right? In my training, I have not seen a malignant hyperthermia case outside of a pig in that time
Me neither.
period.
Me neither.
Yeah.
For 30 years, I haven't seen it.
Yeah, so okay. You covered food, so I'm gonna skip on
Mhm.
to end tidal monitoring.
Yep.
We're watching so many things. End tidal monitoring is like one of the heavy hitter monitors that we have. I mean, obviously all of them are important, but it tells us about whether our tube is in place, our breathing tube. It tells us whether it's kinked. It tells us whether it's hooked up to the circuit. It tells us whether it has a leak. It tells us whether they have cardiac output. It tells us whether they're breathing spontaneously. It tells us so many things. Yes, we're looking for their respiratory pattern, and we will assist them when we need to, which is like if they're not doing their end tidal management on their own, then we will assist them. And there are many strategies to help them tolerate a ventilator if they need it. But ventilation, you have to remember, is not benign. So actually, we give them a lot of opportunity to ventilate on their own if that's appropriate, because that can be something invasive to the body that you want to make sure you have a intentional choice of using it. Okay.
Think I answered the one there. There was one on Instagram. Do you have pre and post hospitalization protocols to ensure sufficient number of hours of fluid therapy in geriatric patients?
I'm sorry, can you repeat that one more time, Brooke? I
Yeah,
just didn't.
basically pre and post fluid therapy for geriatric patients. How long?
So, geriatric in itself would not be a reason for me to give more fluids than the average middle-aged patient, let's say. But if geriatric means that they come with kidney disease, I may need to put them on fluids prior to the procedure, depending on how bad the kidney disease is. If they have heart disease, I may need to put them on fluids before or restrict them during or continue it after. If they have both of these things going on, I may need to modify that even further. So I want the takeaway to be from your question is that I can't know by just geriatric. I have to know kidney status, heart status, all the systemic wellness of the patient or unwellness of the patient, and then tailor the fluids to them in terms of their pathologies, as well as I need to get that blood work that day. People will ask me all the time, what should I do about this blood pressure? What should I do about They have heart disease. And if I say, well, did you check the hydration status the day of the procedure? If the answer is no, I can't really answer you because it depends.
All right, we'll take the last question, Stephanie, on
Yep.
pulmonary risk, and then we'll call it a night.
Okay, healthy older dogs greater than 10, pulmonary risk assessment, ventilator management. Um, are there any pre-anesthetic pulmonary evals beyond clinical and cardiac? How does advanced impact age impact risk management? Um, so I would say one important potential screening that is not necessarily right or wrong, but might be something a place will do. Sometimes over 10, we're taking chest rats just to see if there's any pulmonary nodules
Yeah.
from an underlying neoplasia we don't know. That's that's a choice that your institution might make on whether they want to screen that for you or not. If you have no other clinical signs, I don't know that there's always an indication to do that. So, for instance, if you had an older dog and they come and their cardio thoracic auscultation is totally normal and that pro BMP is normal, and I don't know that I would chase doing more eval on that dog if it doesn't have clinical signs of cardiac disease or pulmonary disease. The same scenario that you come in and the dog's been coughing, I can't tell you whether that dog's coughing because it has lower airway disease or because it has cardiac disease or because it has tracheal disease. So that's the type of situation where we need to ask you to go get more evaluations. That might be chest radiographs, that might be referral to another specialist. So that might be cardio or internal medicine. And then we need to see a lot of our older, smaller dogs have all of these things. They have mild to moderate heart disease. They have lower airway disease, either secondary to that or not. And then they might have tracheal collapse. When we have all of these things going on, it can be harder and harder to manage them, but we can do our best job at managing them if we know about them thoroughly.
All right. Good job, Stephanie.
Thank you guys so much.
Yeah.
Yeah, Gary, I'm gonna
I'm gonna
here,
tell
I'm
the
gonna
folks I'm gonna tell the folks on Instagram goodbye, and it'll be recorded, and I'll let Stephanie chat with them.
all right, guys. Have a good night. I'm going to sign off here. You good,
Okay.
Brooke, if I end it?
Yep,
Okay.
you're good to go.
Bye.
Bye.